Hello, everyone. Welcome. My name is Michael McNutt. I'm the Director of Education and Events for WEDI. It's my pleasure to welcome you to WEDI's virtual spotlight series, Operating Rules Updates with CAQH. It's my pleasure to introduce Robert Tennant, Vice President of Federal Affairs with WEDI.
Thank you, Michael. And let me add my welcome to this very important spotlight event. It's part of a series, and we're going to talk about that in a minute. But just want to go through a couple of slides and let folks who aren't as familiar with WEDI know a little bit more about us. We were formed a long time ago by then Secretary of the U.S. Department of Health and Human Services, Dr. Lewis Sullivan, who was a practicing physician and knew firsthand the challenges that providers and payers faced in exchanging health information. And so he was the instigator to bring stakeholders together. They created what's called the Working Group for Electronic Data Interchange. They produced several reports, which were turned into the thing that we all know and love, known as HIPAA, the Health Insurance Portability and Accountability Act. And ever since then, since we were named in the law as an advisor to HHS, we've been very active and very instrumental in trying to really get good recommendations to the government for how to streamline the administrative side of healthcare. We have CMS and ONC on our board of directors, and we interact with those agencies as well as the agency known as OCR, the Office for Civil Rights. Next slide. And how do we do our work? Well, we affect change through consensus. That is really our strength. We bring folks together through various opportunities, work groups and subgroups, and we'll talk about those in a minute. We have task groups, open public forums, conferences, and virtual spotlights like the one you're attending today. And policy advisory groups now called member position advisories. So we've continued on throughout the years trying to make sure that the industry is represented and that we have opportunities to share recommendations and best practices both to the industry and to government. Our members represent really every facet of our nation's healthcare system, including practitioners in hospitals, health plans, state organizations, labs, government agencies, clearinghouses and other vendors, standards organizations like CAQH CORE, and other folks as well. So next slide. And you can see here, we have a broad set of work groups and sub-work groups. I would encourage you, if you're not already involved, to have a look at what these groups are doing, get involved. As a reminder, when your organization joins WEDI, every single employee is also a WEDI member. So if you have an individual, a colleague who is particularly interested in something like privacy and security or data exchange, there's a place for them. So I would encourage you to look over these work groups, see the types of work products they're producing, the types of issues they're discussing, and get involved. If you want to get more involved or sign up, you can just click on the community homepage or reach out directly to Samantha Holvey, who's on the program today. Next slide. And, you know, when I think about WEDI, I've been involved with WEDI for more than 20 years. I really think of it as a platform and an opportunity to convene. And really our goal is not to complain, but to come up with solutions. And so I think that's one of the strengths of our WEDI community, is to bring folks together to talk about the challenges that we all face and come up with viable solutions, both for industry and for the government. So again, if you want to learn more about our organization, certainly we have a wonderful resource in our website, wedi.org. Next slide. So I wanted to talk just about why we're holding this spotlight series. So as you'll learn from our speakers, two standards development organizations have proposed new standards and operating rules to the National Committee for Vital and Health Statistics. NCVHS is a very important review body that is a federal advisory committee, and they make recommendations directly to HHS. So they will be holding hearings early in 2023. So what WEDI wants to do, and we've been working directly with NCVHS and with CMS in developing an opportunity for the industry to weigh in on these new operating rules and standards. So this is the first of a series of educational events to bring you up to speed on what these proposals are. Next week, I'll remind you, we have a similar spotlight on the X12 electronic transaction standards proposal. This culminates in our event on November 9th. We'll have a 4-hour program free for WEDI members, which will be an opportunity for everybody to weigh in on these proposals. We then will share these recommendations with NCVHS and CMS and hope to guide the industry and government when it comes to these important new opportunities. I will say we're also putting out a survey, and you'll look for that in your inbox over the next day or so. And I would encourage you all to please fill out that survey. These results are critical not only to WEDI, but also to NCVHS and CMS. So take the time to fill out these surveys and share your perspectives with us. And with that, I think we can go to the next slide. As always, with these virtual environments, the key tool in your arsenal is the chat. It gives you the opportunity to weigh in with comments, but also ask questions that we can then relay directly to the speakers. I would encourage you to leverage the chat and share your perspectives. And just as a reminder, the slides and recordings will be emailed to all the participants after the event. And with that, I have the distinct pleasure of introducing our speakers, Robert Bowman, Principal Interoperability Standards with CAQH, and Aaron Richter-Weber, Vice President, Committee on Operating Rules for Information Exchange, better known as CORE. Both Bob and Aaron have been longtime supporters and participants in WEDI, and CAQH has been a wonderful partner with WEDI over the years. So I wanted to thank both Bob and Aaron for that, and also for bringing some enlightenment on these very complicated proposals to our audience today. So with that, I'll turn it over to Bob and Aaron.
Good afternoon, everyone, and thank you so much for joining us today. I am going to share my screen here. Let's see. Okay, great. Thank you all so much for joining us today. Bob and I are going to provide an update on a lot of work that's gone on at CAQH CORE over the past year. Talk about, in particular, what Rob mentioned is the proposed operating rule package that our board sent over to NCVHS earlier this year, provide you with a review of the requirements included in those operating rules, the benefits of those operating rules, and talk about some of our plans for 2023, because somehow it's already October. And then we'll definitely save some time for questions at the end. But first, of course, for those that might be newer to CAQH CORE, and I did see a lot of familiar names on the participant list, I'm going to provide a little bit of background into our initiative. CAQH CORE was founded around 2008 to help streamline the exchange of administrative information in healthcare electronically. The concept of operating rules was widely used in other industries, and CORE was modeled after the financial services industry to create business rules and guidelines to build on standards to help create more uniformity and automation across the industry. Since then, we have developed 8 sets of operating rules with our participating organizations, which represent healthcare providers, vendors, clearinghouses, government entities, associations, standard setting organizations, to help streamline that exchange of information. In 2012, we were designated by the Secretary of HHS as the National Operating Rule Authoring Entity, which means that some of our operating rules are federally mandated for all HIPAA covered entities, and others are available for voluntary implementation. We see our role not only as facilitating industry work groups and subgroups to develop the operating rule requirements, although that is a key part of what we do, and thank you and your organizations for your participation in that. But we also provide a lot of ongoing industry education around the operating rule requirements. We have a certification program to help organizations demonstrate their conformance with the operating rules. And more we're focused on measuring ROI and the benefits of the operating rules through both our pilot and measurement initiative and in collaboration with the CAQH Index. Our board is a multi-stakeholder board representative of health plans, providers, and vendors with a number of advisors as well, including WEDI. And so we really get robust input through that effort. I just want to highlight here and thank all of these organizations for participating in CAQH CORE, many for a lot of years, providing individuals and subject matter experts to our work groups and subgroups, co-chairing those efforts, and really help drive interoperability in healthcare. I mentioned we now have 8 sets of operating rules available for industry implementation, 3 of which are federally mandated: the eligibility and benefits rule set, the claim status rule set, and the payment and remittance rule sets. We recently updated some of the eligibility operating rules as well as the infrastructure operating rules. And we'll talk about some of those updates in a few minutes, but the rules really apply across the healthcare revenue cycle. And we continue to identify opportunities where creating some common guardrails would really create greater automation across the healthcare system. I mentioned our certification program. Currently, about 7 in 10 insured lives are covered by a CORE certified health plan. That is really impressive. We offer the certification program on all of our operating rule sets, and organizations typically go through the process. We're happy to have you speak with a member of our team about the time commitment, about the resource investment, and the benefits of CORE participation, which of course are being able to demonstrate conformance with the rules to both your clients, your members, and even potentially the federal government. So I'm going to give a quick update on where we are related to the NCVHS process. So our board, which all of the board members can be found on our website, but representative of health plans, providers, and vendors, came together and identified a set of operating rules, both updates to existing federally mandated operating rules and some new operating rules that they felt were so critical for industry implementation that we should bring them forward to the National Committee on Vital and Health Statistics for consideration for federal mandate. And as Rob mentioned, the NCVHS is a federal advisory body to HHS on issues related to administrative simplification and a number of other topics. So the process that operating rules go through to from the point at which they are approved through the CORE process. So CORE has a very robust voting and approval process where we have certain quorum and approval requirements at 4 different steps along the process. Once rules have gone through that, that's when they become available for voluntary industry implementation. Then the board will review and submit a letter to NCVHS with recommendations for rules to be considered for federal adoption. This triggers a process where NCVHS holds a hearing and collects industry feedback. For the set of rules that have been proposed most recently, that hearing is scheduled for January 18th and 19th of 2023. There is often opportunity for industry stakeholders to submit comment letters or provide feedback in person during that committee hearing. So we really encourage you to get involved through WEDI with your own organization and really evaluate what would the impact of these operating rules have, not only on my organization, but on the healthcare ecosystem as a whole. What is the value that would be brought to the industry if every HIPAA covered entity were to be in compliance with these operating rules? Once NCVHS receives and evaluates the feedback, they will make a recommendation to HHS as to whether or not the operating rules should be considered for federal adoption. Then up to HHS, but they can go through an interim final rulemaking process. So the rules that the board proposed this round to NCVHS include updates to the federally mandated operating rules. So for those of you who have been engaged with CORE over the past year, or who have attended one of our town hall sessions, not a lot of this information will be brand new today, but probably a good refresher as we get ready to provide feedback to NCVHS. The updates to the CAQH CORE infrastructure rules for eligibility, claim status, and electronic remittance advice. An updated version of the CORE connectivity rule. Currently version C1 and C2 are federally mandated. This is proposing version C4. Again, Bob and I are gonna go over some of the detail of this and what the requirements are in a few minutes. And then updates to the CAQH CORE eligibility and benefit operating rules. So both an update to the data content rule, as well as a new eligibility rule related to the exchange of information for patient attribution. And then we're really excited to have approved a new set of CAQH CORE attachment operating rules for prior authorization and claims. These rules were approved in February of this year. And they address both the infrastructure, how to exchange this information, and the data content to support things like reassociation of that attachment with the prior authorization and claims. These rules are new to CORE. As you all know, there's not yet been an attachment standard named, although we continue to wait to hear from folks for updates there. But we're going to talk a little bit about the value of implementing operating rules and standards at the same time, particularly because this is the first standard transaction where maybe more than one standard might be used, and operating rules can really help create common guardrails between approaches so that expectations for data exchange remain consistent. I will say all of these rules were vetted through the CORE rule development process. So our more than 100 organizations had the opportunity to weigh in and support or not support the requirements and provide their feedback and refine the requirements. And all of these rules had extremely high levels of support. Usually around 90% of CORE participating organizations voted to approve these rules. So lots of industry engagement in the development of these rules and lots of support. So the value overarching of these new and updated operating rules are really to meet emerging and urgent industry needs. So some of these rules, especially the eligibility and claim status rules, these rules were developed more than 10 years ago at this point, the connectivity rule as well. So while they have been used consistently by industry for more than 10 years now, there are new and emerging challenges in our industry that can be better met through additional operating rule requirements or updated connectivity requirements. And this is really important from both a security standpoint and from contributing to safe and effective patient care. The rules really facilitate the alignment of administrative and clinical activities in an environment where healthcare data continues to evolve. So when you think about the need for automating the exchange of attachments. We've been talking about this for years. Let's just do it in a consistent way across the industry. And aligning standards and technologies that contribute to consistent expectations for data exchange, closing gaps, and recognizing the need and the role that standard agnostic operating rules can play to support the industry transition between current and emerging standards. So you'll hear how the attachment operating rules apply to both X12 and non-X12 exchange methods. With that, I'm going to turn it over to Bob to talk a little bit more in detail about the connectivity rules and the infrastructure rule updates.
Great, thanks, Erin. And we're going to just jump right into the connectivity update and provide really some basis for why we decided to update the rule, as well as what are some of the key components of that rule. So on the next slide, you'll see that, as Erin mentioned, we do want to align with the work that CMS, ONC, and how the broader industry is looking at connectivity and how it is adjusting how we as a broader industry need to adopt to and adapt to some of the newer technologies. So as always, our operating rule establishes a safe harbor. So this really allows for your IT systems to build a network from health plan to provider to clearinghouses to vendors. That entire network of data exchange, exists today, and it often uses technology that might be a little older, but we're always trying to kind of move the needle forward a little bit in making sure that we're adopting the latest and greatest. So we continue to support the SOAP interaction between trading partners, as well as we've added the update. The update includes supporting REST interactions as well. So conducting claims or an eligibility interaction or transaction or real-time claim status transaction. All of those are defined in the core connectivity rule in the latest version. So we're making sure that we support not only where the industry is at today, but also where it should be moving towards tomorrow. The update also includes that we continue to align privacy and security and authentication standards as well, because those do advance, and all of these kind of advance at different rates and different times and different versions. So we have to make sure that our core connectivity, again, as Erin mentioned, the first version way back in 2008 and 2010, things have changed over the last decade when it comes to security, authentication needs. And those types of requirements are really foundational for securely transmitting some of our most vital data when it comes to claims, when it comes to eligibility and benefit information. As you'll see on the next slide, the connectivity rules safe harbor is really key to this, building this national connectivity network. And maybe to put some of this into real world context and what this means for many of you who are not that technical. The core rules, for example, built and define very specific data that exists within the interaction itself. So if you're building a SOAP real-time interaction and you're a vendor and you want to start exchanging information between your provider clients and a clearinghouse, your provider clients and a health plan, you don't have to make sure you set up a phone call with all of the developers at the health plan and the clearinghouse and help and try to define exactly what these values are. The core participants have already done all of that heavy work for you. Those definitions and what that data looks like and what those endpoints might be called, all of those are defined. So it makes it much easier for you to plug in and play, going back to the 1990s words there, plug in and play with exactly what your application is going to do. Is it real-time eligibility application that you're building, or is it a batch claims module that you're adding on to a feature that you already have or a solution you already have in the marketplace? Much of that's already defined by the core connectivity rules. So it makes it much easier to, again, plug and play in with your trading partners as you expand your trading partner community. It's much cheaper for you to do that. It's easier for you to do that. And it reduces the time frame that you can actually join into those connections and into those markets. So it makes it much easier for folks to build and become part of that network. With that, we'll move into our updated infrastructure rules. And as Aaron mentioned, our infrastructures really kind of lay the tracks, the groundwork, the guardrails, lots of analogies here, on how to ensure that the system is accessible to anyone that needs to be part of it. So you understand exactly what the technology is, what some of the response times are, all those roles and responsibilities across trading partners. That helps you identify exactly what to do and how your system applications should work. And then you can build your business processes off of those. Going to the next slide, you'll see that we have made some significant updates to our existing infrastructure rules. For example, we moved from an 86 per calendar week to 90% calendar week for your system availability, ensuring that as healthcare continues to change into a 24/7 business model, because care is always being delivered to a patient, that the business components, the business aspects of that can also meet those needs. We've also aligned the most current version of the connectivity to version C4, as Aaron mentioned. We've also updated our companion guide template. So again, one of those tools that the industry uses to better understand connections and how we interact with our transactions, that companion guide is really helpful and has to be able to support more than just X12 transactions in the future, as well as various versions of transactions. We'll have more about that later. But this infrastructure update really helps us understand the current business needs that we weren't meeting previously, and this new version helps meet the business needs of today and hopefully into the future as well. As you can understand, potentially, there are some significant benefits for adopting the new infrastructure requirements. Again, it does align with today's technology and business needs. It does allow for longer and less frequent periods of downtime. Understanding that many of the systems have gone to cloud computing, it takes more time for those systems to be updated. There's more interconnection between systems. It's not just one eligibility module and a claim status module necessarily. Many of these systems are all tied together. And so understanding how the technology is tied together and then how you need to update those systems on a regular basis as health plans and vendors need to meet the growing provider need, how the systems are working is really important for the entire industry to understand. But we do want to make sure that it's available more frequently for people to access and to use. We've also increased and improved the access for the needed data to better serve the patient. Again, having that real-time availability for benefits or for prior authorization, that really helps improve the revenue cycle, ensures that the patient experience is improved, the provider has the data when they need it. And again, as we mentioned, the new version of connectivity really allows for folks to start moving into perhaps API technology or RESTful interactions with their data exchange. And again, having those guardrails up, understanding there are security authentication needs for that data is really important too. And again, the core rules the core rule update for connectivity helps address many of those needs. With that, I'll hand the call over to Aaron to jump into our eligibility and benefits update.
Great, thanks, Bob. As you all know, eligibility and benefits were the first set of operating rules first developed through CORE, and that was because there was a lot of inconsistency in how plans were sharing eligibility information with providers, making it very difficult for them to automate their systems. In 2013, the eligibility and benefits operating rule set was federally mandated. And that is also around the time, 2012, when the CAQH index started tracking the number and the percent of transactions for eligibility and benefits being conducted electronically. So you can see from 2013 to 2021, we've seen a pretty significant increase in the volume of electronic eligibility transactions. And this is, of course, an inquiry to understand information about a member or patient's eligibility, coverage, and associated benefits. We do have an infrastructure rule for eligibility and benefits, as well as a data content operating rule. And that data content operating rule currently includes requirements for health plans and providers to send things, including patient financial information around copays, coinsurance, deductible, remaining deductible amounts, all that information that is really critical for a provider to have to be able to collect from a patient. The eligibility infrastructure requirements include requirements for eligibility to be conducted in real time. And that really was a game changer within the industry, enabling that information to be available to a provider in real time for real-time collections and real-time benefits verification. Since that rule was first developed, lots have changed in this industry. And the core participants spent the better part of 2021 identifying areas where the eligibility and benefits transaction could be enhanced to address some of these new business needs. Telemedicine, obviously something that really came to front and center during the pandemic, but the need to be able to identify what service or benefit is available for telemedicine. So the new rules include some requirements around ensuring providers know what benefits patients have related to telemedicine. Requirements for procedure codes for physical therapy, occupational therapy, surgery, and imaging, getting to that next level of detail to understand what specifically is required under a patient's benefits. The update also adds 71 new discretionary service type codes and 55 new mandatory service type codes for a total of 178 core required service type codes. These are codes in which plans must send back benefit information. The new requirements also require a communication if a prior authorization or certification is required for a core required service or procedure. So that is really critical information for a provider to have in real time prior to service if that prior auth or certification is required. The core participants also expanded to include remaining coverage benefit information in that eligibility transaction. As well as support for tiered benefits. So more granular level information for members of these types of plans to get information on coverage status, remaining coverage, in and out of network determination, and communications around the status of some in-network, out-of-network for the inquiring provider. I also mentioned earlier that the proposal also includes the new, somewhat new, I think it was approved in 2020, single patient attribution data content rule, which requires a health plan to return the patient attribution status, yes, no, or partial, and the effective dates of that attribution within the eligibility transaction. We heard lots of pain from the industry around particularly providers not knowing at the appropriate time or a useful time to impact the course of a patient's care, whether or not a patient is attributed to them. That information is often shared through portals or spreadsheets in monthly intervals or even less frequent, which is really a challenge when you're trying to close care gaps and things like that with patients. So all of these updates, there's a lot of benefits to these updates. I mentioned quite a few of them, but when we're talking about cost savings, we can look at the CAQH index and see that in 2020, the manual cost for an eligibility transaction was the highest it ever has been at more than $15. This is likely based on our research due to the emergence of telehealth during the COVID-19 pandemic, which drove a lot of manual and complex requirements, resulting in time-consuming phone calls and effort. So having that information within the electronic transaction can help drive that cost back down across the industry. We also did a study around patient attribution and found that 62% of medical providers that participated indicated they spent more than an hour reviewing attribution information, and 45% said they spent more than 3 hours. Those that said they were getting the information using the eligibility and benefits transaction indicated they were spending less than an hour exchanging attribution information. So using existing transactions that are already part of the workflow can really help reduce the time providers are spending looking at attribution and understanding attribution. Again, I would highlight, the industry need to adopt and address things like telehealth, prior authorization. These are things we've been talking about a lot over the last couple of years. And then to highlight again, we know that X12, Rob mentioned this at the beginning, is starting to bring forward newer versions of their standards. The process here is always, if there is a new federally mandated version of a standard that has operating rules, that triggers a process within CAQH to review the operating rules and remove any duplicate requirements, because operating rules never conflict or duplicate what is included in the standard. So with that, I'm going to turn it over to Bob to run through the new attachment operating rule requirements.
Great, thanks, Erin. And as many of you know, the attachment process today is often fully or very highly manual, with providers having to go down to a fax or mail or even email the types of documentation that's required to support healthcare transactions. This is usually related to claims and prior authorization. Because these types of documents or this documentation type data is really the bridge between clinical and administrative data, where unfortunately, we haven't seen a lot of technology being moved into this space until really just the last couple of years. So you see there from our latest index in 2021, we're hovering right at 20% as a fully automated solution to submit this data to a health plan for them to interrogate, to remove those PINs or release those claims for payment. This, again, is a challenge and very costly to the industry. If a provider has to drop to fax to pull the documentation from their EHR and submit it to remove the PIN on a claim, that is a lot of time, a lot of energy, and very costly for the provider. At the same time, health plans are having to support fax machines on their end or fax servers to receive this information. Again, very costly on both sides of the equation. So the CORE took this as an opportunity over the last couple of years to develop our operating rules for attachments. Just like we have for every other type of interaction or transaction that we've adopted operating rules for in the past, we first start with infrastructure rules. Similar to what we've done with every other transaction, we have system availability, connectivity, processing modes. Some of these could be real-time or batch processing modes, acknowledgements, as well as the companion guide requirements. This again is for both X12 and non-X12 methods. A couple of unique requirements for infrastructure for attachments include file size, as well as an electronic policy access for required information. Again, specifically for claims, this is important because we need to inform providers that this particular diagnosis, procedure code, revenue code will require that additional documentation to be submitted for the claim to be considered for payment. So if the provider knows this information prior to submitting the claim, they can submit them together. So again, it helps reduce the problems that we have with reassociation. As Erin mentioned earlier, reassociation is very key for the processing of an attachment with the associated interaction, whether it's PA or whether it's claims. And again, because it is a bifurcated process, the attachment may come from a different system, through a different vendor, through a different clearinghouse than where the original prior authorization or claim went through, because those are so different in many use cases and in many instances that reassociation is key to appropriately adjudicating these types of transactions. Is really needed by both the health plan and the provider to marry them back up, either when you submit them or when you receive them for that adjudication. So all key, really important components for infrastructure. We also have additional requirements listed on the next slide for our attachments rule. Again, for both PA and for claim, there's going to be specific data that's needed for that reassociation. So we define what that data is. We define how providers are to submit the data to ensure that not only can their diverse systems on their end reassociate, but also when the health plan receives it, they can reassociate those different interactions and transactions that come in, again, from different systems, different vendors, different clearinghouses, and at different times. We also have information and requirements for health plans that they also can use and recommend to use various coding so that providers can understand hey, I sent in this claim and I got pended for this specific reason. Well, the carts and rocks that may come back on the 835 may not be specific enough. So how can you better inform folks? Well, there's different types of coding that allows providers to identify the specific document, perhaps housed in their EHR, that they can then pull and send to the health plan to ensure that that pend is removed and can be adjudicated more expeditiously. Again, the intent is to help automate many of these systems and applications and interactions so that between the provider and the plan, we're reducing that cost, reducing the burden that is often manual today. As you can imagine, the benefits for adoption on the next slide. As we continue to converge between clinical administrative data between an EHR and a PMS system, ensuring that not only are they integrated, but if they're not integrated yet, how do we ensure that we can reassociate these types of transactions and interactions between a provider and a plan because of that bifurcated system? Part of how we do that is to define key infrastructure requirements so that vendors that are in the space today and vendors that want to be in that space tomorrow, as well as clearinghouses and health plans, they can start building systems and applications and considerations around how to do this better for tomorrow. Again, simple reassociation of claims and prior authorizations really goes a long way in reducing many of the manual interventions that are taking place today. And again, all of this really helps the adjudication of a prior authorization so patient can receive care, and also helps speed up the adjudication of claims so that payments in the next process, next step in the revenue cycle can take place more quickly and more efficiently. And last but not least, some key components here as well for the current adoption of the operating rules. The alignment of the standards with the operating rules enables really streamlined implementation. So if you're one of the more larger plans or a clearinghouse or a vendor that wants to move into the space, having a single process for all of the infrastructure, for example, really helps you implement a system-wide process better, right? You know exactly what the requirements are for connectivity, for using acknowledgements for all the transactions, defining a companion guide for all of the interactions that are going to take place between you and any of your trading partners. As we know, that HHS Unified Agenda signals support for multiple data exchange standards. The core attachment operating rules do that as well because they are standard agnostic. We have operations and requirements for using an X12 transaction as well as for a non-X12 transaction. So if you're going to use an HL7 CCDA and you're using it today, building around that the infrastructure requirements that we've defined in these rules, you can continue to do that. The operating rules allow for that flexibility. So if you're a vendor in this space and this is the best route for you in your use case, whereas you're a different vendor and you're in a different space, but in your use case is totally different, it allows you that flexibility. And that's what we hear from everybody, right? Allowing for that flexibility within not just the technology, but also within the use cases and amongst trading partners to really help benefit and help the entire industry move forward with more automated processes. And again, the consumer cost savings to be realized by moving an interaction today that is faxed around the website to a fully automated solution can really reduce the cost across the industry. Again, up to 75% per transaction can be reduced by going from a fully automated process like an X12 transaction, like a CCDA, fully allow that to be imported into your system, accepted into your system, and moved into your workflow and make it to that claims pend queue that the claims adjuster is working today. That can all be automated from soup to nuts. So again, that cost saving is significant. With that, I'll hand the call back over to Erin for our call to action. Erin?
Thanks, Bob. So we spent a lot of time talking about the rules that have been proposed to NCVHS, but that's not all our teams have been up to. Many of you recall we approved a very large rule set the core participants did at the beginning of this year. The new attachment rules, the eligibility updates, the infrastructure updates. That was a lot of effort. The rest of this year has really been spent on helping determine what's next. So we've had a lot of one-on-one calls with organizations. We've been working with our board to identify opportunities for new operating rules or areas where guidance is needed within the industry. The first is our focus on ROI. We are really committed to standing up a more formal ROI initiative using pilots and measurement to help industry make decisions about their implementations. So we actually have several pilots related to the attachment operating rules and standards either underway or in the planning stages. So we're very excited to share more about that with you in the coming months. We have also been spending a lot of time talking with organizations about challenges related to EHR and practice management data exchange. Part of the challenges we're hearing there is that there's a major distinction between what the large health systems are capable of doing and then what smaller hospital systems are able to do. But there's a lot of opportunity for aligning on common interoperability and integration frameworks here. We are hoping to conclude some data analysis later this year and hopefully publish an issue brief or a blog. And I'll put a little plug there. We are launching a blog soon by the end of this year or early next year on our findings here. Two other key areas, I think these will probably be key focuses for us in 2023 are value-based payments, environmental scans. So you may remember back in 2018, we put out a report on 5 opportunities to streamline value-based payments and create more consistency in how information is being exchanged to support those programs. We are updating that research. Out of that came the patient attribution operating rules, but we have been talking to stakeholders across the industry around, are these still the right pain points and are there new opportunities? So things like social determinants of health, standardization of contracting terms, these are bubbling to the top as opportunities for CAQH CORE and the industries. So we will be sharing the findings from that research towards the end of this year as well, and hopefully launching rule development in 2023. And finally, healthcare claims. We have several operating rules already addressing the claims adjudication process. However, there continues to be opportunity for operating rules. We're seeing through our interviews and environmental scan efforts, persistent variation around submission requirements, emerging technologies and standards, and evolving payment transformation like value-based payment calls for potential new operating rules to drive some standardization in this space. And we're actually having a focus group with our core participating organizations next week. So if you're interested in hearing more about these or getting involved in these efforts, please email us at the address below or reach out to Bob and I directly. Bob and I will both be at the WEDI conference later this month. So if you have any questions about anything we have brought up today, please reach out to us. And I know we have a little bit of time left to answer some questions now as well. Oh, one more thing to highlight here. As I mentioned at the beginning, we do have a lot of education resources available as well. So we have a lot of online tools to help learn more about the work that we do. We do a number of webinars ourselves. We have a lot of FAQs on our website. So if you have a question about the rules, that's the best place to go first. Rob, now I'll turn it over to you for questions.
Oh, great. And as a reminder, you can use the chat feature to enter your questions. We do have a philosophical question from Charles. He asks, what do you see short-term and long-term future of X12 and FHIR? Each one has capabilities versus the other. Are they going to stay apart or will one take over the other?
Great question, Charles. And I think that and again, this is maybe my opinion versus the CAQH CORE participating organizations' opinions, but I think that what we're seeing and hearing and what the industry is looking at when it comes to these more traditional EDI transactions versus a FHIR implementation guide for a particular interaction is that it's use case driven. I can't imagine the billions of claims that are being transacted every year using an 837 will flip the switch tomorrow to a FHIR interaction, right? And FHIR has very specific goals when it comes to real-time data exchange. Much of our claims adjudication today is a batch process mode, right? Everyone submits their claims, the process adjudicated overnight. The payment may come out in a day or two or next week when the 835 is generated. Again, another batch transaction. That process has been working really well for a long time. However, when you need to have blood pressure for a patient, when you need to have a specific data element from a patient or from the provider, perhaps the FHIR interaction and that data component and that IG that is being drafted by an accelerator, they're looking at very specific use cases for very specific needs to meet, the business requirement. So I think that we'll continue to see both develop to meet the business requirements, the business needs that are at hand. I think that perhaps the excitement and vigor that the industry is seeing when it comes to FHIR interactions is that with an EHR, you have the immediacy of the data is available. So how can we tap into that data from a health plan perspective to ensure that we are caring for the patient, to ensure that we're processing data more efficiently for the patient? The same for the provider. The provider has an EHR, they can tap into a specialist EHR down the street, and they can share the information about the patient. That care delivery can be improved. So I think it's going to continue to be use case driven approaches for data exchange. And for either way, either HL7 or X12 or some other format that's in the mix, folks like WEDI, folks like CAQH, and all of our constituents and our participating organizations and members for WEDI, we're going to continue to look at those use cases and find out what's the best approach to move forward. So the discussion is going to be open. It has to be open, I think, and really important for us, for both organizations moving forward.
You touched on this a little bit, but can you explain to our audience a little bit more about the process that CORE goes through to develop these operating rules? I've been involved personally, and I'm interested in you explaining to the audience the lengths you go to make sure each stakeholder group is involved, the numerous discussions, the straw polls, that sort of thing, to ensure that you've got full industry consensus on these operating rules.
Yeah, absolutely. I can walk everyone through that process. So anytime we start or think about starting a new rule development process, we typically conduct an environmental scan. And that's what I talked about, some of the work we've been doing this year, which is, we interview CORE participating organizations, we attend education, we're out and about in the industry trying to understand where the pain points are. And out of that, we can typically identify trends, right, that we then bring to a focus group or an advisory group of CORE participants to say, which of these do you think would move the needle the most and have the most value for the industry from an operating rule perspective? I would typically do some surveying and prioritizing there. Then we'll launch our formal rule development process, which starts with a subgroup. Anyone from a CORE participating organization can participate in our subgroups. You can have one person from your organization, you can have 10 people from your organization, and go through the process of developing the operating rules. As CORE staff, we really serve as facilitators of the effort, and it's the participants that are driving the content and the requirements. We know you have full-time jobs, so we're trying to help in the back room by making recommendations along with support from our industry co-chairs to move the group forward. We typically meet once every couple of weeks with surveys and straw polls in between. Once through surveying, we've identified priority requirements, the subgroup will start drafting the operating rules. And subgroup participants are reviewing the operating rules line by line and providing feedback on a regular basis. Once the subgroup, there is sufficient support, and we typically think of that as around 2/3 support to move things forward. it moves to the work group level. The work group level is considered a higher level review of a full operating rule or a full set of operating rules, where again, the requirements are considered, the impact on the organizations, and we have all stakeholder types participating in these efforts. And if we feel like we're missing a stakeholder, we will do the outreach to try to get them to join us at the table. Once the work group reviews the rule, then that launches the formal voting process. So at the work group level, we need to have, I think it's majority approval and majority participation and 2/3 support. And then it goes to the all core participant vote. And that's core participating organizations that actually would be implementing the operating rule. So health plans, providers, vendors, and clearinghouses, those that have to commit the resources have the final say on the operating rules. And at that all core vote level, we are again looking for a quorum of 2/3 of the core participating organization and 2/3 support for an operating rule. And then it goes to a final vote by the core board. So there's multiple points throughout our process to provide feedback. And, sometimes we get feedback that it's too lengthy of a process, but for us, it's really important to make sure throughout the process that we have that support. And if we don't, we bring it back to the group and they rework it until there is sufficient support. So that's the process that we go through. And once it's gone through that whole process, then a rule is available for industry implementation.
Excellent. I appreciate that. Charles has a follow-up. He asks, do you know if military health uses X12? If so, please provide some facts and use cases. I know the VA is not only using them, but they're actually involved in the standard development process. Are they involved with CAQH CORE as well?
Yeah, the VA is a core participating organization, as is TRICARE. So both of those organizations are regularly providing feedback and using X12 standards.
And I'll add that the vendors that support TRICARE, as well as the DoD, those like Humanis and Teen, WPS, were also involved as participating organizations and member organizations, I believe, for both WEDI and us. And they also participate, and they do conduct the transactions, claims, remits, eligibility, the entire kit and caboodle of X12 transactions, as well as many of the HL7 transactions as well, are part of that process.
Excellent. Last question before we end, it'll be a quick one. The attachments rule, Bob, that you alluded to, it's at OMB, assuming it comes out, which a big assumption. Depending on what is included in the rule, do you envision an updating of the attachments operating rules based on what CMS is proposing?
Great question. I think that, and Aaron, jump in. I think that whatever might be in there, perhaps it's a different version of the X12 transaction or a different version of an HL7 interaction or IG. We can easily update the rules to meet those versioning type requirements. We do that. That's a normal process that we do. And anytime a new version is promulgated by regulation or by the industry. So I think that's a pretty cookie cutter process for us. So if that is the case, it's pretty easy for us to make those adjustments.
Excellent. Well, let me thank you, Bob and Aaron, for a very thorough and expert analysis of these new and updated operating rules. You will be involved, I hope, in our November 9th event as well. I just want to remind folks, this will be a working session designed to really dig deep into the X12 standards and the core operating rules to be able to come up with some recommendations to NCVHS regarding their adoption. So it'll be free for WEDI members. So I strongly encourage you all to attend. And again, fill out our survey. That data is going to be critical for us going forward. So with that, again, I'll thank our speakers. Thank you all for participating, and we look forward to seeing you at future WEDI events. Thanks so much.
Thanks, Rob. Thanks all.